And welcome back. I'm Mabel, Jong. You're watching live coverage of the World Healthcare Congress, coming to you from Washington, D.C., and a very warm welcome back to our virtual audience joining us. I'm so pleased to have right now with me Enrique Conterno, who is the president of Lilly Diabetes. Welcome. Thank you so much for your time.
Mabel, thank you. Thank you for having me here. It's a pleasure.
Well, certainly there's a lot of issues swirling around payment to pharmaceutical companies for their product. What's your position on where we should head towards in terms of reimbursement?
So we have been at Lilly, we have been a big proponent of value-based agreements. And we like value-based agreement because it puts patients at the very center, and it connects the pharmaceutical reimbursement structures with real-world patient outcomes. There are a number of benefits to this type of agreements. On one side, basically, payers tend to see better outcomes, are aligned to these better patient outcomes, but they also get good economic outcomes in addition to clinical outcomes, because you tend to avoid hospitalizations, readmissions, and at the end, the good use of medicines can save cost down the road. So we do like that, and that applies to both private and government payers. And I think for the pharmaceutical company, we get rewarded based on the value that we provide. And I think that's fair. Not all products are the same. And I think we're willing to entertain that, which is if our innovation is truly providing really good value, we want to be rewarded for that. And if not, not. So.
Will Lilly be taking part more in accumulating more data to see if certain drugs work for certain types of patients, and taking that into account as we move forward to try to come up with a better system of payment?
Yeah, that is a great question. Not only are we accumulating more data, but we have already entered into 12 value-based agreements in the U.S. in 3 different therapeutic areas, most of them in diabetes. And I think it's great to see, because we study basically as part of that different patient populations, and we have very defined outcomes that meet the needs of the payers. Of course, there's great value for patients doing that, and we learn as a result of that really how our products perform in the real world. And in a very real way, we are getting paid based on the performance of our products.
We are in the midst of a very serious drug crisis and with opioids. How will the reevaluating of this payment model affect trying to combat that crisis on that front?
Well, that crisis is truly multifactorial and needs to be addressed. I think on Lilly's side, one of the therapeutic areas of focus for us is really pain. So we have a number of pain medicines that we are developing right now. We do believe that could be important in the treatment armamentarium of physicians, and hopefully provide safer, less addictive type options. Now, I'm a big believer in this value-based agreement. There are a number of barriers to bring this to scale, and one of those are regulatory in nature, like providing a safe harbor for the anti-kickback statute, or ensuring that price reporting is clear in terms of how do we account for these value-based agreements, and importantly, ensuring that best price calculations or average selling price in both Medicaid and Medicare Part B respectively are compatible. These pricing mechanisms are compatible with these value-based agreements. So there are a number of things that could be done from a regulatory perspective. There's no need, in our belief, for new legislation to make these changes. And I think we need to look at scale to deal with problems such as diabetes or the opioid epidemic.
Lilly is one of the biggest makers of insulin, and recently you announced that you're heading into the medical device business by a medical device that would deliver insulin to diabetes patients. How was it a risky move to also go into an area that Lilly doesn't have historical experience with?
It is, in a certain way, it could be seen as a risky move. It could also be seen a lack of moving as a pretty risky proposition for us as well. We, of course, brought insulin to the world by introducing insulin commercially in 1923. We've been developing better insulins. We believe that with the convergence of pharmaceuticals and technology, there are opportunities to deliver now better systems of diabetes management, of insulin delivery. So we're developing a number of systems. Some are completely automated insulin delivery systems that includes pumps and sensors. Also the clinical support, the algorithms that are going to basically are going to be individualized for each patient, and they're going to try to provide, at the end of the day, better outcomes. Or just integrated insulin management systems that do require human intervention, the intervention of the patient, but that patient is also getting a recommendation of maybe when to dose, how much, and it's just very exciting for us to move, I think, into this field, recognizing that, creating a system is new for us, but we're excited in terms of the impact that we can have for people with diabetes.
So what is the timeline for that?
Yeah, we are pretty advanced. We expect that we should be introducing some of our solutions in 2019 and probably in full scale in 2020.
And what would that look like? What would the first devices look like in 2019?
In 2019, we look to introduce a pen that is a connected pen, so people will be able to capture their insulin doses and so forth, and the clinical support, the algorithms that basically support that administration. And in 2020, we expect to produce other solutions, including a fully integrated solution, automated solution that may include a pump, sensors, and so forth.
Okay. Enrique Conterno, thank you so much for your time. It's
Mabel,
been a pleasure.
Thank you.
Thank you. And thank you for watching. Stay with us. Much more to come.